constitute a major bond. The major bond 10% total body surface area, or partial thickness bond injury greater than 20% total body surface area in extremes of age, or greater than 25% total body surface area in adults. According to area of bonds, bonds involving the face, the hands, the feet, genitalia, perineum, and major joints. Inhalational joints, inhalational injuries also constitute major injuries, major bonds. Chemical bonds, which could be, there's also electrical bonds and bonds in patients with coexisting medical diseases, or bonds associated with trauma. These are the major bonds. The role of anesthetics in this bond management. Like I said earlier, that bond management is multi. Anesthesia has a very important role to play. Important consideration in clinical outcome of the patients with bond includes early resuscitation, multidisciplinary team management, early surgical debridement, and prevention of complications. The anesthetists usually face a lot of challenges in managing the bonds patient because of the complications or issues associated with bonds, like hypermetabolism, pain management issues, alteration of drug pharmacokinetics, airway problem, temperature control, and substantial blood loss, especially during wound dressing or during skin grafting. Anesthesists are usually involved in initial resuscitation of the bonds patient, and any resuscitation will involve the APC. In terms of the airway is very important and is the area of specialties of the anesthetists. So anesthetists will secure the airway, gain vascular access, control pain, manage the patient in the ICU. They are also involved in the preoperative consultation or preoperative preparation of the patient that are going for surgery. Most surgical patients or most bonds patients may end up in surgery, which could be early surgery or delayed. Some of these surgeries are wound debridement, hysterectomy, wound dressing, or reconstructive surgeries later. Injury to airway and lung. One of the warning signs will show that the patient may be having inhalational injury are history of being trapped in a burning wound. If there is bone, full thickness bone around the face or neck, or change in voice, patient may have twice voice or stridor, or if there is sputum or carbonaceous sputum. Then if there is frank respiratory distress, these are pointers that there may be airway involvement. And if airway involvement or inhalational injury is suspected, immediate intubation must be carried out because further delay will lead to difficult airway because of the mucosal edema and also the edema that will follow the fluid resuscitation. Early intubation is considered in presence of stridor when the patient is unconscious with TCS of less than 8, when there is hypoxia or hypercapnia, when there is full thickness bones on the face, as I said, or when there is suspected oropharyngeal edema, or if there is total body bones of total bones surface area greater than 40, this massive edema is solely initial fluid resuscitation. And in this case, patient should be intubated. Remember that early intubation within 24 hours of bond, transanamic can be used. But after 24 hours, it is risky to use transanamic because of the risk of hyperkalemia from acetylcholinesterase acetylcholine receptor, which may persist for over a year or two. In terms of the circulation, the major bonds, ideally 2 large bore IV lines should be secured, usually away from bond tissue. If there's no clear site or most of the sites are involved, then the bond area can be used, and provided the ester is still sterile. The priority in fluid resuscitation in this patient will be using a large bore IV in the unborn, followed by bottling, or if central venous line may be used. Most of the time in burns, the groins are femoral venous termination can also be used in securing the intravascular access. Fluid resuscitation, the principle here is that intravenous volume must be maintained following burns in order to provide sufficient circulation and to provide the circulation for the vital organs. Not just the vital organs, but also the peripheral tissue, especially the damaged skin, because it is needed for adequate wound healing. For for fluid resuscitation in burns in adults, there's a formula that can be used. In adults, fluid resuscitation can be used in adults if the burns is greater than 50% total body surface area, or if there is 10% burn surface area with smoke inhalation, or in children, burns greater than 10% total burn surface area. Oral resuscitation oral resuscitation can also be used in burns that are not severe, or it can take orally. Fluid resuscitation, yeah. The ideal fluid for resuscitation may be crystalloid, that is ideally Ringer's lactate. But in absence of Ringer's lactate, normal saline can be used. The resuscitation fluid is calculated for the first 24 hours using Parkinson formula. This formula is the percentage body surface burn times weight times factor 4. This is calculated and divided into 2. The first half is given over the first 8 hours. First 8 hours from the time the burn occurred, and then the remaining is distributed over the next 16 hours.
Thank you.
Oral resuscitation can also be used.
Thank you, Dr.
Hello? Oral resuscitation can also be used. Usually, human albumin is used. For maintenance fluid or maintenance in burns dehydration, the Moore and Baker formula can be used. This is 0.5 times percentage burn surface area times weight. This is divided into 2 and then distributed over 36 hours. We'll be given 4 hourly in the first 12 hours, 6 hourly in the next 12 hours, and then the other remaining portion for the next 12 hours. While these fluids are being given to burns patients, it is important to monitor the adequacy of the fluid that is being given. This can be done with a urinary output. So any patient with a massive or severe burn should be catheterized and the urinary output should be monitored. Urinary output of 0.5 to 1 ml per kg per hour should be the aim in an adult. Children, 1 to 2 ml per kg per hour. If this is not adequate, the infusion rate will be increased by about 15%. If urinary output is not adequate, it will indicate hypoperfusion. And bolus dose can also be given, bolus dose of 10 ml per kg. If urinary output is more than 2 ml per kg in an adult, it can be a pointer to over resuscitation, and the fluid infusion should also be decreased. In electrical burns, however, because of massive muscle breakdown and myoglobinuria, and which may cause rhabdomyolysis and subsequent renal failure, the aim should be higher urinary output of 1.5 to 2 ml per kg per hour in adults. Other monitors for the fluid resuscitation include arterial blood gas, the central venous pressure monitoring, and Transanamic Acid can also be used to monitor the efficacy of urinary fluid resuscitation. The burns patient in this serious analgesia, even though we say that full thickness burn is usually on time, it's a mixed picture. Analgesia must be given to burns patient. This analgesia could be more on morphine mainly because of the effect. Mainly opioids, morphine can be used with doses 0.05 to 0.1 milligram per day. IV petidine and tramadol can also be used, and the analgesic doses of fentanyl 1 to 2 micrograms per kg can also be used. Paracetamol and non-steroidal active inflammatory agents can also be used as part of modern analgesia. During the wound dressing, vitamin can also be used analgesia in wound dressing to be given orally or intramuscular at 5 to 15 milligram, 5 to 10 milligram per kg, or analgesic intravenous dose of 0.5 to 1 milligram per kg. Anesthesia for anesthesia are also involved in for burns patients. It could be later surgery or early surgery. And examples of these surgeries are wound dressing, hysterectomy, and fasciotomy. And grafting. But some of the challenges anesthetists encounter in management of these burns patients, like I've said earlier, include the effects of anesthesia, airway management, hemodynamic stability. They may go for emergency surgery, like dynamically stable, and the anesthetic have to dribble with it. Try to stabilize the patient before the emergency surgery, because if patient has a circumferential burns of the chest, the patient is ventilated, patient is intubated and ventilated. So surgery can be done. There's also the problem of thermoregulation important in burns patient. The ECG probes, even inside the central venous line. So these are also problems that the anesthetist may have to encounter. In critical care management, the anesthetist will also have to grapple with a lot of problems, like we have talked about fluid resuscitation and mechanical ventilation. I've also talked about it, that the patient has ventilation. They may need emergency surgery, like to release the chest until the patient can breathe very well. There's also a problem of hypothermia, that's regulation of temperature. Because of the surface or depending on the degree of burn, a patient may be overexposed and may lead to loss of heat and be predisposed to hypothermia. This loss of heat will be by evaporation and radiation. So adequate covering of the patient should be ensured with clean, sterile clothing. Then all available methods of conservation of heat should also be used. Then peripheral temperature monitoring may not be reliable. Then for surgery at that early stage, temperature should be maintained at about 25 degrees centigrade to prevent so much evaporative loss. In terms of nutrition, because the burns is a hypermetabolic state, and because there is because of the increased basal energy requirements, patients needs enough nutrition. Initially, in the first 2 hours to 4 hours, there may be gut edema, mucosal edema, and the patient needs MG2 for the congestion. After which early interval feeding should be started. This early enteral feeding also it helps to maintain the mucosa integrity, because bonds also predispose to falling also that's a pressure ulcer. So also acid prophylaxis is also important in Crohn's patient. H2 receptor antagonists can also be used, like ranitidine, or proton pump inhibitor, example, omeprazole can be used. Due to high catabolic energy demand because of the protein and energy breakdown, high energy and high calories also required in one patient, maybe up to 6,000 kilocalories, as high as that. Protein should be aimed at 1.5 grams to 2 grams per kilogram per day. In adults and in children should be higher, than 2.5 to 4 grams per kilogram per day. This adequate nutrition is also important for adequate wound healing, because if the patient is anemic or if the patient is not well nourished, the wound will not heal well. For infection control, one of the major causes of complication and death is infection. So adequate precautions should be taken to ensure that strict asepsis is ensured and observed in care of patients with burn. There should also be adequate antibiotics covered. Psychological and rehabilitation care is also important. The anesthetist is well versed in this area. Those who survive major burns are often left with severe morbidity, because it could be from prolonged hospital stay, could be they may never go back to their original work, and they are left with severe scare and deformity. So the anesthetist may be in a better position to offer pain and palliative care to these patients. These patients are patients that have acid burn on the face, and usually is what we see in young girls, young ladies, in which maybe in cases of lockdown, you have acid burn on the face, and it will affect the lady for the rest of her life. There's also severe deformity from burns, which make patient not to go back to work, or maybe even become demoralized and everything. And there's this issue of chronic pain. Most of the pain, if it's not well managed in the acute phase, may go to chronic pain and needs to be well managed. And the anesthetists are in better position. Some of the benefits of adequate pain management.
Hello, Dr. Agu. Hello, Dr. Agu. Hello, Dr. Edith.
We've lost contact with her. I saw that the presenting laptop just exited a moment ago. Most likely she's trying to reconnect, ma'am.
Okay. Okay, let's give her a few minutes. We can generate some questions now. People can put their questions in the chat section, because she has gone almost 3/4 of the presentation. While we encourage others to join, please, those that had problems joining before, you can get back to them and tell them that the hitch has been corrected. We regret the inconveniences caused. They should please join us now while we wait for the Agu to reconnect. And then Please let us ask Dr. Yakubu to be on standby. Moderator, over to you, please.
Hello, ma. Thank you very much. Good afternoon.
Okay, Dr. Yakubu, you need
Is
to
that
be
Dr.
on
Yakubu?
standby.
Yes, I'm following.
Good.
Okay.
Thank you.
Thank you, sir.
I want to plead with every participant to be a bit patient, as we expect that Dr. Agu will join, Dr. Edith will join soonest. And if that doesn't happen in a few minutes, we may have to take Dr. Yakubu's presentation, and whenever she reconnects back, we'll complete our presentation. That's one of the challenges with electronic media, so to say. We may not all have the same quality of internet network. Kindly bear with us.
Hello, Dr. Moderator, Dr. Adete.
Yes, yes, ma'am.
I said that some people are putting questions on the chat. While we
Okay,
wait
ma'am.
to come back, we can generate discussion alongside, and we can answer the questions that are pasted. For those of us that have responses to them, we can be called upon to answer. So we do that. We give her about 5 minutes. If she
Okay,
doesn't come back, then we take the next presentation.
Okay, ma. Thank you very much, ma. I think we have 2 questions here. If I didn't miss out on any of them, Dr. Yetunde Oyeyode, thank you for the presentation, ma. Why is large bore cannula preferred to central venous catheterization for resuscitation in major burns, please? And Dr. Mukaila Akinwale is also saying, thank you for the excellent presentation. Is tracheostomy an option in airway management? If some of our senior colleagues would like to answer, please just show by clicking on the raise hand. Under the option more, just click on raise hand. Yeah. I recognize you, and then so that we don't have chorus answers. Time to get through.
Can we please mute our speakers if we are not called upon to talk? Kindly mute your speakers, please, if you're not addressing the group.
And conclude exactly. We have not and with all these challenges.
Hello, there's a call for Dr. Adetoye to take down his link. If since we are no longer using it and we're continuing with this link,
Yes.
Dr.
Yeah, I think so. That.
Yeah, Dr. Briggs.
Yes, yes, President.
Your line is breaking. I said if we could.
She was trying to inform you that that has been taken down.
Oh, okay. Okay. All right.
All right.
Questions on the chat. Can anybody volunteer to answer them? While we give 2 more minutes, and if she doesn't come on, we do a discussion and then we continue with the next presentation. Moderator, over to you, please.
Yes, ma'am. We?
You can attempt to answer the question, and then we do a general. But I see that Dr. Agu has come back. The notebook, one is back.
I've not seen our laptop again.
Hello?
Dr. Agu, are you there?
Yes, she is in the HP15.
Okay, please Share your screen again. Share your screen so that you can complete your
You have not made me a co-host.
Okay.
You have not made me co-host.
Are you Agwe?
No.
Is it the one with
HP15? HP15 notebook. 15 notebook.
HP, okay. Dr. Benny make HP15 notebook. Post. So that she can share her screen.
HP15 notebook. Yes. Yes. It's going up. It's going up. HP15 notebook PC.
Okay. I suggest Dr. Please answer the question on the chat while we are trying to make you a co-host.
What did you say, Dr.
Suggesting that while we are trying to make Dr. a co-host, you should just put questions in the chat box. But it seems that laptop has disappeared. The network around there is so it's no longer there.
Please, can you read out? Let her continue with the talk if we cannot read the screen. So, because we have spent more than
Madam President, ma'am.
there's a whole somebody is sharing using two devices but my suggestion is sorting out the technical issues. Read out for Agu. Let her attend to them. She may not have the chat because she was for a while.
Ma, the challenge now is that we are not sure she's with us. Dr. Edith, if you are there, please signify so that we know that you are with us.
Hello?
What you need to do is remove Agu from 15 notebook PC. Oh, the HP 15.
Is it there?
It has repeated again. Dr. Agu, are you there? Dr. Aku, are you there?
Yes.
Okay.
We are going to read out the questions in the chat box for you while you answer them, and then you complete your presentation. The notebook you're using is not stable. It's coming in and going out, and it cannot be made co-host in that way.
Hold on. Let me change the network provider.
Okay, let's change the network.
Okay. Hello? All right. You can change the network provider. While the technical person is helping you, can you just listen and answer the questions? Okay. Listen on your phone and answer the questions. Is it possible for you to do that, please? Hello?
I'm not sure she's there, ma.
Yeah, somebody is working with her and he said he will help her to change the network provider. So what were the questions that we were to discuss?
Okay, I'll read them out now.
Okay, start with the first one.
Okay, the first one says, why is large bore cannula preferred to central venous catheterization for resuscitation in major burns, please?
Okay. Well, to my mind, a lot of times it's getting the central line, if the area is affected, maybe access. And then there are issues with infection control and all that, having lost most of the skin to the burns, to a major burns. So that is my own explanation for it. Apart from the technical difficulties of doing a central venous catheterization, or even having the facilities readily available. I don't know. Other participants may wish to share their experiences. Hello, Dr. Hamza. Yes, there's a hand up.
Okay.
Dr. B, I think. Somebody B. B's hand is up.
Please unmute yourself and speak. If your hand is up, can't find the microphone.
Dr. Adeta, your network is fluctuating.
But I can hear you clearly, ma.
Yes, but your voice is dragging.
Okay, I will.
It's stable now.
Okay.
So you can repeat what you said.
Okay. I was just asking that I couldn't see any hand raised, but whosoever is raising the hand should please unmute the microphone and then speak. Say what exactly you want.
The person has put a chart. He said it's the physics, that it's because of the physics. That's why the large bore cannula is preferred to the central venous line.
From B.
B. I don't know who is B.
Laminar flow depends on radius.
Yeah. Yes. Again, also the central venous line, it's a central line, it goes centrally, but it may not be a wide bore line. It's a very fine thing. So the flow rate might not be fast enough. I think that's the physics of it. The width, the wide bore cannula will be wider than the central venous access.
Well, I have a slightly different opinion in this case anyway. If
Okay,
there's bones, depending on the percentage bones and the depth of the bones, sometimes you would have lost the peripheral lines that you want to insert that wide bore cannula into to the coagulative necrosis. and lines to be difficult. Most of them are already clogged because of the bones. The challenge is that some people might not have the skill to do a central line, or the area where you're supposed to put a central line is also bones. That may be, but definitely I cannot come to terms with the fact that whichever white ball needle that fellow is trying to insert will be fast delivering fluid than a central line, if a proper central line is what we are talking about. And that will also afford us better opportunity to give drugs through another port, fluid through another port without interference. You can do about 3 things or more, depending on the type of catheter you are using for that central line. So it will be a better one either way, but there's no hard and fast rule to this. You know, it depends on the kind of patient we are dealing with. If it's just a bones on one part of the body and large veins are spared, that is much easier, it's less costly. You can divert your resources to some other things that the patient will need, including maybe parenteral nutrition if the bones area is very wide, and so many other things. So it's not, I don't think it's one hard and fast rule. Treat each patient as he or she presents. That would be my game.
Thank you, Dr. Adetoye. HP 15 notebook is back consistently now for about 2 minutes. Can we try to add it as co-host while we encourage Dr. Agu to finish up her presentation?
Okay. Dr. Brixma, kindly help us.
Yes, please.
Assign the status of a co-host to HP
15 notebook.
Yes, ma'am.
Sorry, please, may I just ask if anybody knows the lumen size of a central line? I know they are in sizes, but the standard central line, what's the lumen size?
Hello?
I think the lumen sizes are indicated on each kit. I don't the ready value now. It tells you the dimensions of the box. I mean the size of the catheter. Central venous line okay, Dr. Elumelu has put in another contribution, the chart. She says that it's 4 to 7.5 French gauge. The sizes of the central venous line is 4 to 7.5 FG. And there's another contribution by Dr. Julio Carr, and he says that the Hagen law flow is inversely proportional to the length of the tube, amongst other things. Hence, the central line is not ideal for initial rapid resuscitation, unless otherwise indicated. Dr. Rukewe says that we can have up to size 9 FG. So, we should know that the length of the line affects the gauge and the flow rate eventually.
I am on the next now. Triple lumen central venous catheter set, Sedinga is saying size 7 French. The lumen is triple, and the lumen gauge distal 16G. Size 7 triple. Attack diameter 2.5 mm. But that's what I found on Google.
Okay. Yeah. Yes. We're on point because
if it's 16, then it's white ball.
Yeah, but it's 3-way. It's not each one of them that okay, it's 16G, but what about the length, the issue of the length?
Yes, the length would be a factor.
Okay. It gets up to 20 centimeters in length.
Yes, that's true.
In burns, if you have seen a burns patient and you are in the immediate resuscitation, I will say do what works for you. For me, I've had to resuscitate burns patients at the acute stage. And honestly, that's not the time to start sending a central line.
That's true.
But if you have a skilled person who is very fast at it, and the area is spared from the burns, and you have a central venous cannula kit available at hand, why not? There's no hard and fast rule. That's what Dr. Adetoye was trying to say to us. They never say never. Do what.
And that table is also telling me that the flow rate is 62 mils per minute.
Okay.
Length 15 centimeters, lumen, distal portion 16G, proximal 18G, media 18G.
Okay, 62 mils per minute is quite fast, actually. So if it works for you, if you can set in the line fast, why not? Why not? But I know in my hospital, it took us almost an hour on Thursday to convince a colleague who we couldn't get her lines to set a central line for her. In the end, she said she didn't consent for it, and we had to do a cut down. We set a very small cannula, which we started with, and we did a cut down. I think for TAH. So the issues are about central line. It's not a firewood of one hand, as one of my friends would say. You need two hands to carry it. So it's not something you just rush into. So Dr. Agu is back.
Okay, ma'am.
And I think she has been made co-host on that system?
Not yet.
Please, let's make her co-host and give her the opportunity to finish.
I can't find her laptop again, ma.
It's gone down. It's down. It's not
okay,
down. It's
down.
Under Garba in my system, the Facebook HP notebook.
Okay, yeah, HB, okay.
Yes.
Dr. Breeze, kindly make her a co-host so that she can come up and then complete her presentation. The other question says, is tracheostomy an option?
Sure.
Dr. Hector, would you like to comment on that? On the issue of tracheostomy?
Hello?
Hello?
Yeah. Yes.
Hello?
Okay, Dr. Agu is back.
Okay, let me ask, is the tracheostomy an option?
Yes.
It's like Dr. Agu is talking.
If
Dr. Agu
hello?
is back.
If there is no... Hello?
Hello, Dr. Agu.
Hello? Okay, tracheostomy is an option if you have a good hand that can perform it in a fast time, because we're talking about trying to do intubation early enough to avoid the setting of edema and subsequent difficult intubation. So I think early intubation should be the intake, not a tracheostomy. Tracheostomy can come later.
Okay.
If there is need.
Okay.
Thank you, Dr. Agu. Adetoye, please go ahead.
Okay, the presenter. Okay, thank you, ma. My question is the slide on injury to airway. What does HO, H/O stand for?
History of.
Okay, history of being trapped in a burning room. Okay.
Yes, ma'am.
Okay, so what is the justification for preferring burnt area over central line for siting intravenous cannula? What is the justification for preferring burnt area over central line for siting intravenous cannula?
The justification is the fastest means.
Why burnt area?
Okay.
The fastest easy means should be the option. Not like if you are not conversant with setting up a central line, I think it's better to go for the one that you are conversant with that is faster.
Okay. Now we know your mind. We've been hanging before you came. I'm making contributions. Okay. Field registration is faster with large blood canopy.
Sorry, as a follow-up, Dr. Agu.
I think so.
Dr. Agu.
Yes.
Go ahead.
Please, one may want to argue a little or to have a different opinion from what they are saying. We know that citing an intravenous line in a bone area, that line will be precarious in a way in that is an area of injury. You may not be able to secure that line in that place. Coupled with tissue edema, infections, risks around that bond area. I'm just wondering whether it should be a standard practice to say, because from your lecture you said that in order of preference, citing a line will be the unbound area. If you are not able to get a line in the unbound area, then the bond area before central line. So if the central line is not affected, why don't you rather go to a place, to an area that will be more, that will be safer and more stable, more secure than citing a line in the bond area? That was just what was playing in my head. Thank you.
Thank you, sir.
Go ahead. I thought you wanted to provide an answer to what he said, or a comment.
No, I've already said something that the fastest and easiest way should be the option. If, like I said that I caveat there that if the bone skin can be used, if the extra is still sterile. So if there is a good line, they can still be used.
Okay. Okay. Thank you very much. A lot of contributions on that too on the chart. How do we assess the level of dehydration in a burns patient?
Level of hydration.
Yes.
I said in the presentation that when you are hydrating, you monitor the patient. I talked about the passing catheter and monitoring the urinary output. Then using the central venous pressure to monitor can also be used to monitor the level of hydration.
Okay. Any other contribution, please? Or we should move on?
Please, let's move on because of our time. We're already eating into the second presenters.
Okay, ma'am. But if W meant, okay, let me just read down to the last. You said full thickness bonds are painless. Can you elaborate, ma'am?
Sorry.
Because of the distortion of nerve endings. Because the nerve endings are in the dermal area, not in the epidermal area.
Okay. Thank you.
But
that is all I have. That's all I have on the chat box for now. Let's move on to the next presentation. I'm sure Dr. Yakubu is with us. And let me quickly introduce him before we move on. Dr. Yakubu, you can start sharing your screen while I introduce you. Dr. Yakubu Said Yusuf Yakubu holds an MBBS degree, a diploma in anesthesia, postgraduate diploma, and is a fellow of the West African College of Surgeons. He's a senior lecturer and consultant anesthesiologist at the Ahmadu Bello University, Zaria, teaching hospital in Zaria. He has been the head of anesthesia department in ABU/ABUTHC Zaria since 2017. Dr. Yakubu is a member of the International Association for the Study of Pain, ISP, and member of the Society for the Advancement of Patients' Blood Management, SABM. No wonder he's interested in telling us about blood conservation. He's the current treasurer of Nigerian Society of Anesthetists and the Northwest Zonal Coordinator of the Society. His interest lies in patients' blood management safety in anesthesia, and pain management. Please welcome with me Dr. Said Yusuf Yakubu for his presentation. You please click on the PowerPoint presentation so that we can have a full screen presentation from you. Then you have 40 minutes from now, sir. Thank you.
Have you seen my slide?
Yes, very clearly, sir. So
Okay,
you can
so
go
I can
ahead.
go ahead. Good afternoon, senior colleagues. Good afternoon, colleagues. I'm Dr. Saidi Yakubu. This evening, I'll be talking about perioperative blood conservation. My presentation will follow the following outline: introduction, history of blood transfusion, blood conservation, patient blood management, and then I will talk about strategies for blood conservation, and then I will conclude. Of our introduction, blood conservation is a combination of strategies to avoid the transfusion of allogenic blood and to improve its oxygen carrying capacity. There are pharmacologic and non-pharmacologic strategies for blood conservation. Anemia is a common finding in trauma, surgical patient, and patient in the ICU. And most patients with anemia, they receive blood transfusion for correction. However, we all know that perioperative blood transfusion is associated with adverse events and this is a table showing us some of the adverse events associated with blood transfusion, the transmission of infections such as HIV, hepatitis B virus, hepatitis C virus, bacterial infection, parasitic infections such as malaria. And then also there are transfusion reactions such as acute hemolytic transfusion reaction, ABO incompatibility, allergic reactions, and transfusion-related acute lung injury. Transfusion reaction may be mild or severe. It could also be allergic, febrile, or hemolytic. Whenever there is a reaction to blood administered, the blood transfusion should be stopped and maintained along with normal saline, and the blood should quickly be sent back to the blood bank. I would like to give a brief history of blood transfusion. The use of blood for medical treatment dates back to the 17th century. William Harvey discovered the circulation of blood in 1628. James Blundell successfully transfused human blood to treat postpartum hemorrhage in 1818. Blood typing and cross-matching between donors and patients was first introduced to improve the safety of transfusion in 1907. The blood group O was identified as a universal donor. First blood bank was established at Leningrad Hospital in 1932. And blood banks moved toward an all-volunteer base in 1970. First HIV blood screening test was licensed and introduced by blood banks in 1985. Please, somebody is talking. Kindly mute your... blood conservation has certain guiding principles.
Dr. Yakubu, please.
Yes,
the host should please mute everybody. Then you can then unmute your own microphone. The host, please mute everybody. Then Dr. Yakubu will mute himself. Go ahead, sir.
Thank you very much. Blood conservation has certain guiding principles. One, that blood transfusion is associated with complication. Two, there are options to blood transfusion that actually involve the patient in decision making on which type of treatment they should receive so that they will not receive blood. And then three, it is associated with reduction in the length of hospital stay and cost of hospitalization. And there is also decreased pressure on the blood bank for limited blood. These are the various blood conservation strategies. They include pre-op, intra-op, and strategies. And then there could also be pharmacologic and non-pharmacologic. Pre-operatively, anemia should be corrected using iron, folic acid, vitamin B12. And then among the pharmacologic means are the use of tranexamic acid and epsilon aminocaproic acid, Fresin. Then among the surgical, which is tourniquet and diatemy and others. And of course, for anesthesia, we could do hypotensive anesthesia to aim for 50 to 65 millimeters of mercury of mean arterial blood pressure. And then again, can be considered hemodilation. There could be pre-op autologous, also do cell salvage. And then, of course, one could use alternatives to blood. Currently, there are modified hemoglobin use. Similar to blood conservation is the new concept of patient blood management. It is a clinical concept with the aim of preventing unnecessary transfusion for improved patient safety and outcomes. It is a multimodal, multidisciplinary approach that requires cooperation between the anesthetists, the hematologists, and the surgeons. It involves early detection and treatment of preoperative anemia, tolerance to anemia in the postoperative. These are the pillars of the patient blood management. They include optimizing the hematocrit preoperatively, minimizing blood loss intraoperatively, optimizing tissue oxygenation intraoperatively, and lowering the transfusion trigger. One could go as low as saying, okay, I will not transfuse until maybe the HB is 7 grams per deciliter. As I mentioned earlier, the patient blood management can be looked at preoperatively, intraoperatively, postoperatively. Preoperatively, one should aim for assessment of anemia 4 to 6 weeks before surgery. That way, one will be able to administer iron to build up the blood. One should also identify and treat the anemia, treat absolute or functional iron deficiency with oral iron or IV iron, and consider erythropoiesis stimulating agents. The second pillar, preoperatively, one could identify and manage bleeding risks, and then review medication that the patient is taking. Is the patient taking antiplatelet or anticoagulants? The third pillar, the management of anemia and the improvement of tolerance. One should compare estimated blood loss with the patient's specific tolerable blood loss, assess and optimize patient physiologic reserve and pulmonary function. Intraoperatively, as I mentioned, could be surgical, could also be anesthetic techniques such as performance of regional anesthesia. And then one could also decide to go ahead and consider patient positioning. Postoperatively, certain things can be done. One should reduce the amount of blood that is being taken to test the patient. Also, the frequency can be reduced. Something very important as far as blood conservation is concerned is the issue of Jehovah's Witnesses. Blood conservation and patient blood management is clinically relevant surgeries involving the Jehovah's Witnesses because they refuse the transfusion of blood components such as
Metron, oxygen is down. Are we aware? Okay, it's coming up now.
White blood cell plasma and
it's just coming up now.
Also, autologous blood that has been removed from the body is not being accepted by Jehovah's Witnesses. What are the specific strategies for blood conservation?
I went down, but it's just coming up now.
Patient blood management. Dr. Onwoye, please mute yourself. The World Health Organization defines anemia as a condition with decreased number of red cells and their oxygen carrying capacity. It is associated with inability to meet the body's physiologic demand. It is defined by a hemoglobin concentration of less than 13 grams per deciliter for men and less than 12 grams per deciliter for non-pregnant women. Prevalence of anemia before operation has been found to be as high as 60%, so it's a serious condition. Preoperatively, there is need to take history, conduct physical examination, and review investigation results. And then history of inherited or acquired bleeding disorder should be documented. Patients should be asked if they are taking non-steroidal anti-inflammatory drugs or other anticoagulants. Type of surgery should be considered as it relates to the risks of bleeding. Physical examination will look out for anemia and bleeding tendencies. Severe hypertension may cause severe bleeding, therefore it has to be controlled. Full blood count should be performed 4 to 6 weeks before surgery, as I mentioned earlier, so that one could administer hematinics. An anemic patient should receive preoperative hematinics. particularly for Jehovah's Witnesses. Acute normovolemic hemodilution, which involves planned collection of the patient blood and subsequent refusion of the autologous blood. Collection of the patient blood for Jehovah's Witnesses has to be done in the theater, and there should be no loss of connection with the circuit. Cell saver can also be used, but there should be no loss with connection with the circuit. Hemodilution also allows surgical blood loss to occur at a lower hematocrit. One could also do controlled hypertension to decrease blood loss, and certain medication can be used: esmolol, labetalol, sodium nitroprusside, and so many others. And then, of course, anesthetic techniques such as neuromuscular blockade, deep sedation, and general anesthesia to reduce the patient's oxygen consumption and improve survival. Again, it is very important that normothymia is maintained intra-op, because hypothermia, when the core body temperature is less than 36 degrees centigrade, causes increased blood loss. Management of blood loss is influenced, as I mentioned earlier, by the surgical technique, whether it's a fast surgeon, a resident doctor, a consultant, and then the anesthetic blood loss reduction strategies such as regional anesthesia, and then pharmacological management using antifibrinolytics. Minimally invasive surgeries such as laparoscopy surgery associated with the reduction in blood loss as compared to conventional surgeries that the patient is open up. Meticulous hemostasis is vital, it's important in preventing perioperative bleeding. It has been shown, regional anesthesia has been shown to significantly reduce perioperative loss. Maintenance of balanced physiology, such as avoiding hypothermia and acidosis, aids in coagulation. As I mentioned earlier, hypotensive anesthesia is relevant. Appropriate patient positioning assists in reducing blood loss by improving venous drainage. One could put the patient in the left lateral position so that there will not be compression of the, there should not be caval compression. Intraoperative cell salvage. If blood loss is greater, if the blood loss is greater than 500 ml, there is need for someone to consider the use of intraoperative cell salvage. It is performed with the use of a double lumen suction device to collect the blood. Blood is stored within a reservoir with added coagulants. Once enough blood is collected, red blood cells are washed, filtered, and suspended in saline and returned to the patient. This is showing machine blood is washed and then returned back to the patient. Antifibrinolytics such as Tranexamic acid and epsilon aminocaproic acid. An example, there is also a protein, but recently, it has been stopped actually because it is associated with increased death during the perioperative period. Essentially, they inhibit fibrinolysis by their action at the active site on the plasminogen. They inhibit the activation of plasmin, which break down clots. So the whole aim is to make sure that the clots are not broken down. Tranexamic acid should be used prophylactically in major surgery where perioperative blood loss is predicted to be high. It has been shown to significantly reduce perioperative loss. Post-operatively, the frequency of blood collection for tests should be reduced. Reduce the use of post-operative drain. In the past, surgeon put in a lot of drains in order to prevent hematoma formation and infection, but it has been shown that it causes loss of lot of blood. Surface salvage can also be used post-operatively so that the lost blood drains can be reinfused to the patient. In conclusion, blood conservation strategy and patient blood management are clinical concepts that improve perioperative patient safety and outcome. Though blood transfusion is life-saving, its administration to patient increases morbidity and mortality during the perioperative period. Anesthetists should collaborate with other clinicians to practice blood conservation strategies. Thank you very much for listening to some of my references. Thank you.
Thank you very much, Dr. Seydou Yakubu, for keeping to time. That was very concise and straight to the point. Dr. Yakubu has taken us through the history of blood transfusion, a lot of interesting thing about the history. He also told us about this, the importance of perioperative blood conservation. He emphasized the role of the anesthetist, the surgeon, and the hematologist, the roles they had to play to make sure that there's good blood conservation, the wrong patient is not transfused, and the right patient is not over-transfused as well. And alternative sources, what we can do to ensure before, during, and after surgery, what can be done to ensure that there's little or no need for blood transfusion, because blood is not made in any factory. Humans donate it. And he has also emphasized the risk associated with blood transfusion. And to cap it all, he has told us that we can do the best with the little quantity of blood we have if we try to observe all that he has highlighted for us. Thank you very much once again, Dr. Yakubu. Let me see the chat box if you have questions for you.
Thank you, sir.
Yes, sir. Thank you, sir. Are there any limitations to intra-op cell salvage?
Yeah, there are. It's an expensive and technical procedure. Yes, the machine is expensive, so that is a limitation on its own.
Okay.
And then, of course, if it comes here, then we have to learn how to use it. Thank you.
Okay. What is before you leave that, what do you have to say about this EAT set that we talk about? And you know, some people even use layers of gauze to sieve the blood salvage from maybe the peritoneum if it is not contaminated and the like. So what would be your comment on this, sir?
Yes, thank you. That is what is available for us here. Of course, you cannot compare with what the machine can do. The machine, of course, will do better because there is still the likelihood of transmission of some infection or other debris, you know, using the gauze. But the machine does it perfectly. Thank you.
Okay. Thank you for the presentation, sir. How will you approach a bleeding Jehovah Witness who presented for emergency surgery but refused blood transfusion in any form?
Yes. The first is actually to counsel the patient, discuss with the patient on the various options that are available for that patient's treatment. And then everything should be documented. So options will be given, and then if the patient accepts, then one moves forward. But then in a situation whereby it is actually needed that the patient should receive blood and the patient refuses, then it has to be documented, and then other options should be directed, ringer's lactate, sodium chloride infusion, and then tranexamic acid. You know, they can all be used, you know, to control the bleeding.
And the colloids will be the alternative as well. Imacel and likes could also be used in such a patient. Then mechanical methods like tourniquet, if it is an extremity and such things, just try stopping the bleeding so that I can conserve the little and do the best you can.
Thank you very much.
Okay, is hypervolemic hemodilution a blood conservation strategy? Hypervolemic hemodilution, is it a blood conservation strategy? Somebody wants to know, sir.
Yes, it is. And the whole aim, you know, when you increase the blood volume using fluids, you know, you dilute the hemoglobin. So even if there is loss, it's minimal hemoglobin that is lost. Yes, it is a blood conservation method.
Okay, sir. Thank you.
Dr. Yakubu.
Okay.
Thank you.
The reason why I asked that, because even in some books, hypervolemic hemodilution is not included, or it's what we practice.
Yes.
That's why I wanted to know your perspective.
Thank you. Yeah, and I saw in the literature too that actually is one of the, actually it's an African literature from Ghana. So I believe that's, yeah. And somehow it has worked for us.
Yes, from your explanation, it's actually a way of conserving red cells. You know, when you dilute it, that means for each volume of blood you are losing less red cells because the PCV will now be relatively low. It is not an absolute thing. It's not the real thing, but you've over diluted. So for every ml of blood that is lost, it will contain less red cells because it's the red cells that are actually carrying oxygen. That's the principle we are trying to play around with.
Thank you very much.
Thank you very much, sir, for the concise presentation. Please, sir, is there a time limit for the administration of transanamic acid to reduce blood loss in major surgeries?
No, I have not come across. I know you can administer 10 to 20 milligram per kg every 6 hours, but I have not come across where, okay, there is a time limit, then you have to stop. We hope that, of course, by the time one administers that amount 3 or 4 times, should be able to control.
Sir, could it be that that fellow was actually trying to ask if you are going to give it as a bolus push or in an infusion? Maybe that's what the fellow was trying to express.
Oh, okay, yeah. It has to be administered, of course, slowly. I think in the past I saw a literature saying 1 gram can be, but yeah, I can't remember. Sorry, yeah.
Okay. I think it is better to add it to fluid, you know, so that because I've seen occasions where transanamic acid actually presented with a complication of hypotension.
Okay.
So because of that, it might not be the best to give it as push. Add it to some mils, maybe 200 mils of normal saline and run and watch as you give. It's not that no cost. Okay. How available and financial implications of the cell survey technology? Okay, how available is cell survey technology and what will be the financial implication to the patient? Maybe that's what the fellow wanted to answer.
Yes, for now, we don't have in our center. And I'm not sure if there is any center that has it here. Of course, those that have, they may let us know, but I know it's expensive.
Okay, sir. Maybe whoever is our center will say it along the line as part of the comment. How will you manage children of Jehovah's Witness who are in need of blood transfusion?
Yes, the same followed for their parents. The parents are there, you discuss with them, and then you arrive at a consensus. But of course, ethically, it can reach a level that perhaps there should be some legal consultation to go ahead. If, for example, one noticed that the child is dying and then the parents have refused the blood, that should be involvement of a legal committee.
Thank you very much, Dr. Yakubu. If I'm allowed to say 1 or 2 things on that, in my center, I've seen parents who said, my baby is here to have a form of religion. When the child grows up, that's when he will belong to any religion. Just taking the patient quietly, don't tell anybody, do as you like, but don't let my people know. And some will insist that no way, you mustn't transfuse, it's a Jehovah's Witness. And we've also seen in the newspaper of a case that was even taken to court. And the doctor eventually won, the institution won against those parents, though the child survived. Please, how can we get the PowerPoint? Okay, that is for the management team. Or what do you recommend as the best way of estimating blood loss, sir?
Yes, that's a tricky question. Of course, intraoperatively, you know, blood is collected in the by suctioning, and then of course the blood on the gauze that were used, the blood and on the drains, the blood on the dressing, the blood on the flow. Perhaps the one collected in the blood collection bottle might be a better estimate, even though we all know a fully sucked gall might contain up to 15 mils of blood. So a blood that is collected and measured will be better. But then again, that is, one has to be sure that other fluids are not collected or are not mixed with that blood.
Thank you very much, sir. For our
Thank
younger
you.
ones, visual method, gravimetry, colorimetry, and so on. Go and read more from the textbooks. And it has been said by studies have shown that the surgeons underestimate blood loss much more than the anesthetist, though the anesthetist underestimate blood loss despite all the efforts. So we should bear all this in mind and be on the edge. Thank you very much, sir, for the concise presentation. Please, sir, is there a time limit to the administration? Okay, somebody has also asked that. We've answered that. Are there contraindications to the use of self-survey systems, sir?
Not that I am aware of. Of course, if patients say no, I don't want self-salvage, that is a contraindication.
Okay, sir. Sir, let me add to that. In cases where maybe the fellow is trying to come up with the idea of the blood being contaminated, in such cases where you have, the self-salvage, the automated self-salvage mechanism overcome that, where you have maybe amniotic fluid, things like that. Can it? Or in that case, too, it should be abandoned?
Yes, I have not seen in the literature, but I believe that for such a robust system, that should have been considered. You know that, of course, if you are collecting blood, likelihood that there might be some infection and all that, and then the system takes care of that.
Okay, thank you, sir. Is transanamic acid contraindicated in a patient on anticoagulant for pulmonary embolism and undergoing an urgent surgical procedure?
I'm not sure. I have not come across that.
Okay. For pulmonary embolism, okay. Maybe some other people will need to contribute to that later. I don't think it should be cast in steel. That shouldn't be cast in steel. It should be individualized based on what you are getting. Evaluate the patient again. Let the hematologists evaluate. Let them carry out some tests and tell you in which direction you are going. When you talk about coagulopathy, it could be hyper or hypo. So determine this and then decide on what to do. Thank you very much for the lecture, sir. What do we say in cases of children whose parents are Jehovah's Witnesses and they decline blood transfusion for the child? In situation where no, we have answered that. Sir, please, how we won't go about a child of Jehovah who needs this thing is really coming up. Okay, you can go as far as going to court. I think the challenge you're having in Nigeria is the delay in court processes. In some other advanced countries, as we are speaking now, you can go to court if there's a need. It's not only about blood transfusion alone. They do that a lot when it comes to termination of pregnancy for medical reasons. So you can institute a case now, and you'll be heard immediately so that they can determine it and you can go ahead. Please, if the patient does not accept blood transfusion in an emergency situation, is high risk consent? Is high risk consent also important?
Yes.
That's the way they put it.
Consent is very important. Of course, the patient has to be counseled and everything documented.
Okay.
I noticed that Kalu has been raising her hand. I don't know if she has already talked. Yes.
Okay. Whoever has been raising his hand, please unmute yourself and say something. Okay.
Okay.
Yeah.
Yes, okay, I've unmuted. Thank you very much, Dr. Yakubu, for your very beautiful presentation. Thank you very much, everybody that has contributed with very interesting reactions. I'm very happy the way we have discussed this subject. My contributions are, as I was listening to the answers, I just felt that I should share some of my experiences in some of the things I have learned in recent years.
I noticed that anesthetists were very involved. We have let me start by saying that we have a bloodless medicine and surgery unit in our hospital. And initially, I was very skeptical because the leader is a Jehovah's Witness. And I think it was born out of his desire to help the Jehovah's Witnesses. He's a surgeon. So I was very skeptical. But I kept attending their meetings, particularly when I was CMAC. I couldn't help because, I mean, by positionally, I had to open some of their meetings and all that. One thing I became very curious when I saw the number of top-class anesthetists that were involved in the bloodless medicine efforts. So I decided to attend the Society for Advancement of Blood Management meeting in Baltimore. And when I got there, the number of anesthetists and all that, in fact, I went with the leader of the bloodless medicine unit in Johns Hopkins Hospital, Professor Steve Frank, for a dinner. And we had people from all over the world. And my eyes really opened to a lot of things. First of all, ever since I came back, I have noticed that by default, when people, surgeons particularly, when they put an anemic patient on the list, and you say, why are you bringing this patient for surgery? A PCV is so and so, or HbA. Oh, the patient has 2 units of blood. That is the first thing we are doing wrong. Oh, the patient has 4 units of blood. Oh, the patient has this. That is the number one thing we do wrong. The first management of anemia is not blood transfusion. So we must learn what Professor Steve Frank calls keeping the patient's blood within the patient. And that starts in the preoperative period. Some patients are taking blood thinners. Some patients are taking, even apart from medications, NSAIDs and a lot of things that, and we don't even ask because most of the time we don't have an anemia clinic. So that is one area we need to look at. These patients that we are bringing for surgery, if we bring patients that are already anemic to surgery, they don't have the capacity to cope with massive bleeding, particularly when we have, when we are anticipating a massive blood loss. Anemia is a reason for cancellation of elective surgery. Then the issue of fibrinogen. Fibrinogen has come out as a very important management strategy in those countries where it is available. It's something that we need to look at the literature and see where it works out. For those of so many of us are flying out of the country now and practicing where these things are available. Tranexamic acid is something we use very much in our center. Our center was one of the centers for Lancet surgery. And a Lancet study, the study that was published in the Lancet. And usually for adult patients, we give 500 milligrams bolus and we put 500 milligrams in the infusion, even before skin incision. And you find out that there's very minimal blood loss. And somebody has already mentioned tourniquet techniques and all of that. It's amazing how we do myomectomies now and you hardly see any bleeding. And there are so many scalpels that even people use and other methods of coagulating blood vessels. Even among the Jehovah's Witnesses, they have what they call minor fractions and major fractions. The major fractions are the ones most of them will not accept. And just like any religion, at the expense of, I hope I don't offend anybody, including myself, you have very, what somebody has called SU, Jehovah's Witnesses. So they are the ones that will not accept any blood fraction. But you also have those who will accept minor blood fractions. So the importance of taking a history at the beginning of surgery to know what exactly does this patient accept and what does this patient not accept. In Inglewood Hospital, also in the US, they, out of their passion to begin to look after these Jehovah's Witnesses who were not accepting blood transfusion, they started a bloodless surgery unit. In fact, I think it was from them that the patient blood management thing came out. The whole idea of patient blood management is that the center should not be on the blood. The center should be on the patient. How can we best manage this patient? So those who do not need blood, who do not accept homologous blood transfusion, we manage them without homologous blood. Those who can accept, So, and then they found out that these patients that were not accepting blood transfusion, they were actually having better outcomes. And I think that, because by default, we want to transfuse. I think everybody was afraid this patient is not accepting blood. How is the patient going to cope? So they were giving better care. They get the fast surgeons to work on those patients, better monitoring, and they found out that the patients were leaving the hospital. The length of hospital stay was shorter. ICU admission was less, and there's so many things. So there's a lot to learn from patients. We should not rush. The lesson is that we should not rush to transfuse patients. And then lastly, coagulation studies. So we need to explore the use of thromboelastography, ROTEM, and other methods of rapidly checking coagulopathies intraoperatively and managing them rapidly. In our hospital, we had a Jehovah's Witness who came in for an obstetric surgery and lost a lot of blood, ended up in the ICU with a PCV of 1. There's a publication in Anesthesia and Analgesia on that patient. The patient survived and was successfully discharged. So we need to the basic principle is we balance oxygen availability with oxygen consumption in favor of oxygen availability. Thank you, everybody, for your attention.
Thank you, Dr. Kalu. We appreciate your contributions, Ma. Let's go on with the questions. Ma, what's the difference? No, somebody's already directing the question at you, Ma. What is the difference between minor and major blood fractions? Dr. Kalu.
Okay, I was trying to unmute myself. I ended up doing video, and I think I can be heard now. If you look at their literature, the major blood fractions will be red blood cells, white blood cells, okay? So for those Jehovah's Witnesses who do not accept major fractions, they could accept fibrinogen, for example. They could accept some of the blood coagulating factors. Here in Nigeria, we are used to transfusing whole blood, but all around the world, it's not whole blood that is transfused. The patients are transfused with what component of blood they need. So that's where, dividing major fractions and minor fractions come in. So that for those patients who will not accept red blood cells, but they can accept coagulation factors, in events that you have done coagulation studies and you have found out that this patient is at risk of a coagulopathy, you can give the patient those fractions, and then it can be a life-saving measure.
Thank you, Ma. Our colleagues are really requesting the organizers to please put the slides on the NSA platform. So prior to the exams. So is there any legal cover for an anesthetist who declined treatment to Jehovah's Witness based on the fact that he or she doesn't want to receive blood? Dr. Yakubu, please.
Thank you, sir. This is an interesting question. Well, as a physician, I think one shouldn't decline attending to a patient. But of course, if the doctor is concerned of the likely lack of safety for the patient, or there will be poor outcome, that doctor can report it, so that the legal team, will consider, and then a decision can be taken.
Okay. So after please, sir, with continued blood loss after a transanamic acid bolus administration, is there a place for a repeat?
Yeah, as I mentioned earlier, you can administer 10 to 20 milligram 6 hourly. So perhaps if it reaches 24 hours and there is continued blood loss and you are concerned, then of course other team members should look at the situation and then decide on what to do. I have not come across in the literature exactly the time to hands off, but I will check. Thank you.
Okay, thank you very much, sir. I also think since transanamic acid is not the only way of tackling blood loss, I think so many other things to be going on at the same time. This is just one of the things to be done, and we should respond appropriately based on individual patients. Those are the questions on the platform for now, except, okay, somebody says by MDCN rule, you have to refer the patient to a qualified and competent physician rather than just declining care. Some people accept to be transfused, but no blood available. Do we refuse them? There's usually a legal team. Somebody is also saying there's usually a legal team in each institution which can be involved for medical, legal implications, okay, in each hospital. So we will learn from all this. You wanted to say something, sir?
No, it's okay. Yeah, I know legal, yes, is very, very important. Whatsoever one does, there should be appropriate documentation, and then the ethics should be followed.
Okay. And the presentation, I want to add that your interaction with the patient and the relations will make a lot of difference. You can actually make them see reasons why you feel it is not safe in this center or under your care to undertake such a risk when you cannot do this. Explanation is not a fight. You are not fighting them. You're only saying, I don't feel comfortable, it's not too safe within my domain to undertake this because of this reason. This is the best I can offer. The things will be sorted amicably, and they can move on to another center where such things can be done, or bring in another expert who can do better. That doesn't reduce you or reduce the institution. Thank you.
That's true.
Well,
thank you very much.
In the absence of this, I want to thank Dr. Any other comments? I want to thank Dr. Saidu Yakubu and Dr. Edith. If I'm even finding it difficult to pronounce the surname, Dr. Edith, if you are still on the platform, I want to thank both of you for accepting to present to us and for the brilliant presentation and the way you've answered the questions. On behalf of all members of Nigerian Society of Anesthetists and the Executive Council and the organizers of this weekly webinar, I want to say a big thank you to both of you. While I hand over to the NSA President, Professor Pastor, please.
Thank you very much.
In a round off. Thank you.
Thank you for the opportunity to present.
Thank you. Thank you very much, Dr. Adetoye, for the excellent moderation and for handling the crisis, the near crisis situation, and offering us an alternate platform. We thank God we're able to upgrade our platform. We want to apologize to all those who tried to join in earlier but couldn't join in. We're sorry for that hitch, and also for the little technical hitches we had with Dr. Agu's presentation. We apologize also. We want to thank all the members that joined. The participation has been very good, and I'm highly encouraged. Today we had 154 participants as at now. There were more earlier, but some have left. And I want to plead with us to continue, stay on with us. We still have some sessions ongoing before the exams. So join us. And also, we want to plead with our members, please, we depend solely on our dues to generate funds to pay for our capitation and other things. Kindly pay your dues. The things to be put up, it will be put up right now, the account details, so that members that are still online can see it and pay. We appreciate those who have paid in recent times. And we promise that the presentations will be on the YouTube channel and also on the NSA website so that we can access them. And those that wanted to be on the platform too, we will see how we can plead with the we'll see how we can plead with the presenters to give us access so that we place it on the different platforms. So the next week's presentations, I will hand over to Dr. Briggs to tell us about next week's presentations and close up for us. Dr. Briggs, over to you. Okay, if she's not readily available, the next week is mechanical ventilation by Dr. Joe Otopala. The first part of mechanical ventilation. The part 2 will be taken by Dr. Gafar in April. So, but next week, after the presentation by Dr. Joe Otopala, we'll be talking about exams. It will be a short session on exam techniques for the residents. So tell them to join in. We'll be talking about the different parts of the exams and how we can tackle it to improve our outcomes. Thank you very much, everyone, and have a good evening and have a good time for the rest of the weekend. I'll see you some other time. Bye for now.
Thank you, Ma. Thank you.
Bye-bye.
So we're going to do our photo shoot. Those that are on can put up their cameras while we take few pictures. For those that are around, are still around, because you can take your screenshots. Okay, Yakubu, you're there. Okay.
Thank you.
Thank you very much. Is
Thank
Dr.
you,
Agu still around? Let's have her picture. Dr. Edith, are you still there? Is Dr. Edith still on? Thank you, Dr. Yetunde. Thank you for being here. Dr. Adetoye, have you taken your screenshots?
No.
Thank you, Dr. Hussein. Okay, let me take you. Dr. Olateju is there. Dr. Olateju, we didn't hear anything from you today. No comments.
Well done, ma.
Well done, my brother.
My president, well done.
Dr.
Olateju
was watching his boy from the sideline.
Moderator. Wonderful moderator.
He was watching and praying for his boy from the sideline.
Okay, I can see Dr. Akafa, Dr. Hussein, Dr. Ebu, Dr. Isobara. I'm going to take your screen now and share it. Thanks for joining. So we'll have a session. Those that have questions about the exam, we'll just take 20 minutes or 30 minutes to discuss the exams next week.
Okay.
We'll have people from both West Africa and national giving us comments about
what to do, how to approach the exams and all that. We hope that that will help since the exams are fast approaching. So if you have any questions or any thing to ask about how to approach the exam questions or how to answer certain questions that you think are challenging, you can share it with us. We'll do our best to give suggestions and advice. But you know, ultimately, the exam just is a test of its own self. Nobody can predict. It can go either way. Okay, Dr. Kalamu, I can see you all the way from Liberia. Dr. Samui, thank you for joining.
Thank you, Ma.
Thank you, Dr. Mbawike. Dr. Wandu, we cannot see your photograph. Dr. Egu, I've greeted you before.
I'm driving, Ma. Dr. Wanda on the line. Thank you, Ma.
Multitasking superwoman.
But I took a screenshot. I did. I took a screenshot myself.
Okay, all right. Okay, good. Just share it so that people will know that people are attending these programs. So
all right.
Thank you, everybody. I have to sign off now. We'll see you next time, next week, same time, same station. Dr. Bapa, I can see you. Dr. Obodo, Dr. Mbawike. Okay, let me take these people now.